Hi, my name is N Van Regenmortel. I'm an internist and intensivist in Antwerp, Belgium, and I'm going to talk you through 3 lectures on water and sodium homeostasis. This is the first part, and it will deal with normal physiology. The second part and third part will be uploaded separately. Let's first go back to basics. I always found it really impressive how with just regulating 2 things, sodium and water, we can measure 2 physiological processes of vital importance, namely osmoregulation and volume regulation. Just by middling with just some water and just some sodium, kidneys and other organs can regulate these 2 enormously important physiological processes. So osmoregulation is the regulation of the proportion of sodium to water. How much sodium is there in relation to water? And what we sense here is the plasma osmolality. And we all know this typical formula. Most of the time it is dependent on the number of electrolytes. It is easy to say it's 2 times the sodium. Of course, there's also chloride and potassium and magnesium, but more or less we can say it's 2 times the sodium plus the glucose divided by 18 plus the urea divided by 6. And of course, these numbers change a little bit depending on in what measure you express these concentrations in the plasma. The plasma osmolality is sensed only on one place in the body. It is sensed in the hypothalamus by the osmoreceptors there, because all of the blood is the same constitution in all of the body. It is just regulated in one place. On the contrary, as opposed to volume regulation, that is difficult measuring places throughout the body. The effector is 2 important things. The first is the very important hormone ADH, or antidiuretic hormone, or vasopressin, which is a typically regulated, or which is typically acting on the collecting tubules in the nephron, and the action of ADH will lead to a high urinary osmolality. From the moment plasma osmolality is increasing above 280 to 90, then we will then ADH will kick in and it will try to dilute. It will try to concentrate urine by retaining water. From a certain time, thirst will kick in, and of course this is necessary to supply or resupply our body with some extra free water. And what the effect of plasma ADH concentration is that urinary osmolality will increase and urine flow rate will decrease because of it will be depleted from free water. So it all works, osmoregulation all works with the excretion or the intake of water. On the other hand, we have volume regulation, and now we regulate the absolute amount of water containing sodium, of course. Now we will try to regulate a volume, and what is exactly being sensed is called the effective circulating volume, which is kind of a virtual concept. And of course, just like our Swan-Ganz catheter and our central venous line, it is very difficult to measure volumes. So most of the time, these sensors measure pressure, and all these pressure sensors are distributed all over the body because all these typical regions of the body need different pressure regulations. So we have of these pressure sensors in the carotids, the cardiac artery, in the atria, in the renal afferent arterioles. The effectors are a little bit more complicated than in osmoregulation because there are many of them. The most important ones are in the sympathetic nervous system where adrenaline and noradrenaline are produced. Very important is the renin-angiotensin and mainly aldosterone system. And again, we have some ADH there present that will regulate volume. Speaking of aldosterone, this important hormone is working on the distal part of the distal convoluted tubule, and the first part of the collecting tubules, and it will lead to sodium and subsequent water reabsorption, leading to a low urinary sodium. So you have already noticed that ADH is present in both the osmoregulation and volume regulation, which is quite interesting, of course. And this is, of course, necessary because sometimes the body has to prioritize. When there is a combination of hypoosmolality and hypovolemia, of course, the body will prioritize hypovolemia, and therefore ADH will be secreted a little bit more avidly in situations where hypovolemia is present. So from the moment plasma osmolality is low but hypovolemia is present, ADH will kick in a little bit earlier than in the normal situation. This is aldosterone, and I put this slide in because it's sometimes a little less intuitive why in the urine osmolality can increase without urinary sodium increasing. This is because of the work of aldosterone. It will, by its action, it will reduce urinary sodium and it will reduce urinary chloride, but it will at the same time increase urinary potassium and increase urinary ammonium. Therefore, it is perfectly possible that urinary osmolality and urinary sodium go different ways. This is a very important couple of slides that you really need to comprehend good later on to interpret what can go wrong with sodium and water regulation. So it's important that you follow with me a little bit here and see what is the impact of every of these 5 or 6 situations that are there on plasma osmolality, on plasma sodium, on intracellular volume, on ADH secretion, on urinary osmolality, on extracellular volume, and on urinary sodium. So you can see clearly the difference between these two regulations. So let's first have a look at the situation that we are ingesting lots of sodium, whether it is hypertonic fluids or it is just a very big bag of chips, potato chips. When we ingest sodium, plasma osmolality will increase, and this will of course lead to an increase of plasma sodium. Both go the same way, of course. This will make intracellular volume decrease a little bit, and the action of the increased plasma osmolality will cause that ADH kicks in, vasopressin will be started to get secreted, and we have now a higher or an increased urinary osmolality. This is osmoregulation just by the addition of sodium. On the other hand, we have volume regulation, and what we have now here is that we add some hypertonic saline, our extracellular volume will increase, and this will aldosterone go to decrease a little bit. Less aldosterone will cause an increase in urinary sodium. Second situation, just add or drink some free water, some water or an infusion with, for example, glucose or dextrose 5%. This will cause plasma osmolality to go down, to decrease, and this will cause plasma sodium to decrease. This will cause, on its side, intracellular volume to increase, and now plasma osmolality has gone down, so ADH will return to a minimum. At the same time, by the action of ADH, urinary osmolality will reduce also. On a volume regulation side, we see that the extracellular volume increases, and on the other hand, by again less need for aldosterone will cause urinary sodium to increase. The third situation is the administration of a liter of isotonic saline solution. So isotonic to blood, so this will not change plasma osmolality, this will not change plasma sodium. Of course, intracellular volume will remain the same in this case. ADH will do nothing or will not be secreted. This means that there is an equal amount of urinary osmolality. It will not change either way. On the other hand, extracellular volume will increase by this infusion of isotonic saline, and therefore, again, urinary sodium will increase. Now look at a situation of dehydration. Put a few men in a sauna and take off their beers. And what we now will see is that we lose free water, so plasma osmolality will increase, plasma sodium will increase, we get slightly hypernatremia, and we will get thirst, of course. But first, intracellular volume will go down, will decrease, and this will be one of the symptoms of dehydration, is mental change. In the case that plasma osmolality increases, we now know that antidiuretic hormone will be started to get secreted, and this will lead to an increase of urinary osmolality. At the other hand, we now, from a volume regulation point of view, we lose water, we lose volume, so extracellular volume will go down, and now it's the time that aldosterone will kick in, and it will cause that urinary sodium will go down. The final situation is a situation where we lose isotonic fluid, for example, in hemorrhagic shock or in trauma. What we now see is that plasma osmolality will not be affected, plasma sodium will not be affected, intracellular volume will not be affected, so ADH will not be affected. At the first moment, I showed you the slide that ADH will kick in because the prioritization of hypovolemia over plasma osmolality, so eventually ADH will get in or will kick in, causing urinary osmolality to increase. On a volume regulation point of view, extracellular volume will decrease due to the blood loss, and urinary sodium now will decrease due to the action of aldosterone. When you have a good look at these complex situations and you have a good understanding of what is happening there, you can more or less deal with any situation, also in the pathophysiological situations that we'll talk on later. Common mistakes is that you could expect that urinary osmolality and urinary sodium could tell you everything right now on the spot. This is not true. Sometimes you need some more samples to get the good picture. This is that sometimes urine consists of urine that was produced many hours ago, giving something more of a strange image. So my advice is to check and recheck urinary osmolality. It is a very closely regulated thing that will change in minutes. The second common mistake is that some people do not realize that plasma sodium is not in proportion with volume status, that plasma sodium is not in proportion with urinary sodium. They have not a proportional relationship, and that urinary osmolality does not have a proportional relationship with urinary sodium. And I again refer to this table here. You can perfectly have a plasma sodium that increases while the extracellular volume increases, for example, when giving hypertonic solutions. But you can perfectly have the situation where plasma sodium will increase where extracellular volume goes down, for example, in dehydration. And so there's no proportional relationship there. There's also no proportional relationship between plasma sodium and urinary sodium. Plasma sodium is osmoregulation, and urinary sodium is a marker of aldosterone in volume regulation. So the both measurements can go both ways. And finally, urinary osmolality and urinary sodium do not have a proportional relationship. ADH causes urinary osmolality to increase, aldosterone causes urinary sodium to decrease, and these hormones sometimes work together and sometimes do the opposite thing. So that's important, and I explained to you how that is possible by the increase of urinary potassium and the increase of urinary ammonium by the action of aldosterone. And then finally, another common mistake is that believing that oliguria is always a bad thing, and I'm very clear on this one. And oliguria is a marker of problems. But oliguria is actually a great thing to have when you are dehydrated, when you're hypovolemic. I love being oliguric when I'm hypovolemic, of course. And oliguria got a bad name by all these systems that use oliguria as a marker of acute kidney failure, or but of course, in the end, um, um, it is a marker of a kidney that is quite doing the right job. And the worst or the least nuanced thing that we can do here is try to treat hypovolemia with furosemide, which is of course completely crazy, but still happens quite a lot. You don't need to treat oliguria with diuretics in 99% of the cases, because this is just a kidney that is doing the best job. And I truly advise you to read this paper, Acute Renal Success. It was published many years ago, actually in my birth year in '76. Um, Oliguria has a certain logic, and the logic is situated here in what we call the juxtaglomerular apparatus. You all know from physiology this macula densa cellular structure that is responsible for a mechanism called tubuloglomerular feedback. Let's call it the policeman of the loss of sodium and chloride in water. What is happening is that normally in the proximal tubule, almost 80% of the filtrate will be reabsorbed, and the concentration of sodium and chloride will be quite low from the proximal tubule on. So from the moment that we have a problem in this tubule, when we have acute tubular necrosis, for example, and the action of the proximal tubule and the loop of Henle and the first part of the distal convoluted tubule will not do its job correctly, then the great risk is that we will lose we will lose this reabsorption, and we will lose in minutes an extreme amount of volume and sodium. So the problem is that we need some policemen there to guard this situation, here at the level of the glomerular to the tubulogranular feedback system, to avoid that we will lose all these ions. So from the moment there is a severe damage on the tubular level, the policeman at this system will shut down the glomerulus and will avoid further filtration. And this is, of course, the reason for oliguria, luckily, because otherwise we would die in minutes out of due to hypovolemia. So why I think oliguria is really underappreciated is that when in the case of hypervolemia or hyperosmolality, aldosterone and ADH will lead to oliguria. Luckily, I'm very happy that this system exists. But even in a case of acute tubular necrosis, ischemia, toxicity, what we will have is that the policeman should kick in, it should constrict the afferent arteriole, and we will have oliguria to protect us from losing all these ions. Of course, GFR decreases and the blood urea nitrogen will increase, and that is the price for a physiological protective mechanism. Just imagine that there was no policeman there, we would lose everything and we would die with a normal GFR and a normal blood urea nitrogen. But that is that, isn't it? Finally, I'm going to use a few words on the fractional excretion of sodium. You all know what it is. It is the proportion of excreted sodium at the end of the collecting tubules over the filtered sodium in the glomerulus. And when we rearrange a few of these formulas, we know now that FeNA is the urinary sodium times serum creatinine divided by urinary creatinine times serum sodium. We all know it as a marker of, or as a distinguishing tool to distinguish prerenal azotemia, prerenal oliguria from renal AKI. The remaining intact nephrons that are not shut down by the GGH clear more sodium in less urine. But some people, including myself, value it as a tool to assess hypovolemia. Of course, when the aldosterone is acting there, we could see a decrease in FeNA, decrease in this fractional excretion of sodium, and by looking at very, very low phenas, we could interpret this as the action of aldosterone, and as such as hypovolemia as the action of a hormone that is trying to deal with hypovolemia, which is a very, very sensitive marker. But there are a few caveats. Of course, FENA is screwed up by the use of diuretics, so don't use it there. Second, it is affected by GFR and by tubular function, and also by sodium intake. And I'm going to take my final minutes to give you a few mathematical examples to illustrate this. Just look at patient A, who has a GFR of 105 ml per minute, a serum sodium of 140 millimole per liter, and who is being treated with 2 liters of fluid with 54 millimoles per liter. So when we do this for a few days, the intake to this solution will match the output. So the excreted sodium is 108 millimole per day, and how much sodium is filtered, it's the clearance times the sodium concentration times the number of minutes in a day. So we filter around 20,000 millimoles per day of sodium. So the FENA in this patient is 0.5% when we are not looking at dehydrated patients or hypovolemic patients. So it's just 0.5%, which is in steady state right now. Patient B has a GFR of half of the patient A, and for the rest is treated with the same amount of fluids. Now we see that the FENA here will be higher. FENA will now be 1%. So in patients with a decreased GFR, it is very difficult to interpret FENA as a marker of hypovolemia. But look at the second example, where patient A is the same patient as in the first example, but now patient B has also a normal GFR of 105 ml per minute, a normal serum sodium of 140 millimole per liter, but now is being treated with normal physiological saline, 2 liters of it, or 308 millimoles per day. Now we see that FENA is going up with 1% and will now be 1.5% or much higher than the lower FENA in patient A that is treated with a low sodium content solution. So what I want to point out here is that if you are going to interpret FENA as a marker of hypovolemia, you have to be really attentive to the amount of sodium the patient is used to his diet, or the patient was treated with in the past few days on a in the hospital, because this FENA of 0.5 is not pointing out especially more hypovolemia than this FENA of 1.5. Is just because of these patients got more sodium. So that is very difficult and very important to be accounted for when you interpret FENA, when you're using it as a marker of hypovolemia. And this was very nicely illustrated in this paper by from the Netherlands by Johanna van Wijk and Dr. Schröder on the interpretation of FENA. This was, I think, in children. So thank you for your attention on this part. This was on normal physiology, and we're going to continue later on into other sessions on hyponatremia and on hypernatremia. Thank you again for your attention, and see you soon.